how does your institution deal with the dynamics of the nursing shortage and the shortage in workforce as a whole?
Great, thanks. And thanks for having me here. It's an honor to be able to speak with this group. So this has been probably the number one issue for us since the middle of the pandemic, when we really realized just how dependent we were on our healthcare workers. We, of course, always knew that, but it became really front and center in the pandemic, where we realized there was sort of a linear and unbreakable relationship between having the workforce that we needed to take care of patients and keeping our doors open. And so this has been something we've been focused on intently for a number of years now. And I'd say we're trying to tackle this on multiple different fronts. So we anticipate that shortage that you described probably continues to get worse for the next decade, that the gap in demand for healthcare services will continue to go up, and the rate at which we're training new healthcare workers will not increase at the same rate. And so it's just the gap's going to continue to widen. And so we see this as requiring multiple different strategies in order to close that gap. Some of them are the more straightforward. We bought a nursing school, and we're expanding that nursing school as rapidly as we possibly can. If the plans play out the way we anticipate they will, it'll be the largest nursing school in the United States, probably in about 4 years. But even at that point, we'll be training about 30,000 additional nurses in total. That's not graduating each year. And so it's still, that's meaningful, but it's still a bit of a drop in the bucket in terms of the impact that it can have. And of course, we can't retain all those nurses inside HCA. They're going to go be nurses wherever they want to be nurses. And so it helps us solve that problem, but certainly doesn't completely tackle it. We're doing the same thing on the graduate medical education side, because the problem is actually there for physicians as well. And in their specific areas within physician pools that are worse than others. Anesthesia, radiology, hospital-based physicians, these are all critical to us continuing to be able to provide acute care services, and we have massive challenges in those spaces. So we're the largest provider of graduate medical education now. We train about 5,500 residents a year across HCA Healthcare. So we started both of those initiatives prior to the pandemic, so it sort of looks like we really knew what we were doing. It's sometimes better to be lucky than good. But now we have those two initiatives. We're continuing to expand upon them to try to do our part to increase the entire scope of the workforce. So that'll help. It'll take care of a piece maybe, but probably the biggest thing that we need to do is really in the area that I work in my role in care transformation and innovation, and that is, how do we help healthcare workers work at the top of their license? How do we maximize the value that a nurse, an LPN, a tech, a pharmacist, a physician can create in our hospitals, maximize the time they're spending caring for patients, make that job easier and more pleasurable to do so that they want to stay in healthcare, and in acute healthcare specifically, because acute healthcare is probably the hardest place to attract healthcare workers right now. And so that's why we started this entire initiative around care transformation and innovation 2 years ago, standing up a dedicated team that is entirely focused on how do we redesign healthcare delivery in our hospitals to take advantage of some of the best technology that's available in our industry and other industries, so that we can eliminate administrative burden, return clinicians to the bedside, to what only they can do at the top of their license, and try to mitigate that gap that's growing by eliminating some of the work that we're asking them to currently do and offloading that to other people, to artificial intelligence, to automation. So we see that as probably the biggest lever that we can pull. It's also probably the hardest one, because it involves redesigning the way clinicians deliver care, which, if you've worked with doctors and nurses, we're a little bit resistant to change. So it's hard work, and I say that as a surgeon who would absolutely be on that side if I was still practicing. But we see that probably as the best path forward for the next 5 years if we're going to weather this massive gap that's about to occur.
So we are very resistant to change, but we're very good at identifying problems and telling you all that you should fix them.
Good point.
First of all, I thank you for having me at the conference, and congratulations on the success of it. And also, Sanjeep, the point you made about paying for the scholarships so that people graduate without debt is really terrific. I wish we would have had that in medical school, but that's really an amazing commitment to your students in the program. So I agree with what Mike talked about. The only thing we didn't do was buy a nursing school, but that was a good idea. The problem is only going to get worse, as pointed out, and it's going to accelerate getting worse, because if you think about the projection for the crisis in workforce, it is continuing on the trajectory. It's worse now after the pandemic. But the other challenge that we're going to have to deal with is the population's getting older and living longer, and we're going to need more nursing care to adapt to that population, care for that population, both inside the hospital, which is going to become more acute, right? Because hospitals today are becoming almost all intensive care units, particularly as we start to push some of the less acute stuff at home. But that at-home stuff can't just be done by machines or computers. I mean, people have to be watching those patients, particularly as we push the acuity out. So our challenge is going to only multiply. I think we are, in the clinic when I was there, we were doing all the tactical things, and Pat Rios is certainly capable of probably talking about it more recently in the last 2 weeks than I am. But we're trying to to support our nursing colleagues. We're trying to bring salaries in alignment, making sure that we're not only competitive, but we are the most competitive. So we're doing all the things you would typically do, but I think the sweet opportunity or sweet spot is really to understand how you deliver care differently. One of the partnerships that we now have, the clinic now has, is with a company called Palantir, and others are using them as well. And what we've done with Palantir most recently is we've brought them in, and they're a computer software engineering company that played in the defense space, and now they're branching out in other industries. They use AI to accelerate programming and learning and application of technology. We've thrown them on problems that really are very labor intensive. So one of the things that we piloted with and developed, and now we're rolling out across the organization, is a nursing scheduling app. And it sounds small, but our nursing managers were spending 4 to 5 hours a week, sometimes more, doing floor nursing schedules on an Excel spreadsheet, sometimes on pads. And Palantir, working with us, has designed a program that basically automates that. And it's eliminated the need for the nurse managers to spend time on manual scheduling. And by the way, the nurses love it. I said to our chief nursing officer before I left, I says, what did you do? Because the nurses don't love anything. And they're like, no, this really works. They love it. And if you think about that, right, so we're thinking about ways, healthcare is thinking about ways of making the job more efficient, taking things away from them that they don't need to do. That's the second point, is anytime something needs to be done in a hospital or on the hospital floor, the nurses can do it. Add to the nurses. Mm-hmm. And what we really need to do is think differently about re-engineering the function and listening to them around what's important and what's not important. And that is as important for a hospital to tackle, and it's also important for us as a regulator or an accreditation of regulations to tackle as well. Because there's things that we ask hospitals, nurses, physicians to do that they probably don't need to do. The third thing that I would say is important as a solution that we haven't tackled yet is how do you push the care down? So medicine is a very traditional kind of tiered legacy practice, and not only for medicine, but for nursing and other healthcare professionals. Only doctors can do certain things, only nurses can do certain things, only aides can do certain things, or more likely the argument is aides can't do anything. We have to really understand that there are things that other professions do, push people to the top of their license, but also take some of the responsibilities that maybe doctors don't need to do, push them to the nurses. Likewise, take it away from nurses, push it to the aides. There's a body of evidence that suggests, just for instance, that nurse practitioners and nurses are better at managing some chronic disease conditions than doctors. Because you can assign a nurse or a nurse practitioner to just do that, and they become very good at it. And it's no different than a surgeon who's only doing one type of disease process or one type of operation. And we don't want to do that because we say, well, a nurse can't manage diabetes, or an aide can't administer drugs. They can. And we should be thinking differently about how we empower those groups of providers, those groups of professionals, to really take some of the burden away from what people are doing on the top of their license.
That's great. I'm just going to go back across the street and let everyone know that aides can deliver medications according to the Joint Commission, so it's going to save us a lot of time.
Stand by it.
Well, I too appreciate the opportunity to actually be spending an afternoon with a group of people with an engineering background as opposed to a group of angry physicians sitting in front of me. I am not an engineer by background, but I do try to play one every day in my work. And that's because I think, to the point that Mike and Jim both made, the solution to this problem doesn't rest in unique solutions like building or buying your own nursing schools. That pipeline is constrained and will remain constrained. The solution to this rests in redesigning the work of the healthcare deliverers. That is about re-engineering work processes. And so while we have done what most organizations have done, we have 6,500 nurses at Duke. We've experienced as high as 25% turnover. When you have a knowledge-based workforce like that, 25% of whom turn over in a year, a lot of knowledge walks out the door, a lot of new knowledge needs to be imparted. It's an extraordinary churn. And the consequence of that is there are likely to be gaps. So beside doing things like raising pay, which I think we've all done, I mean, nurses' salaries have appropriately gone up given the work they do. Many of us have also been confronted with the issue of workplace violence. Beyond pay, workplace violence is a factor that has driven many of our healthcare providers from this. And I think you're all keenly aware of just some of the horrific events that have occurred, perpetrated against people that actually come to work every day trying to care for people. But the real issue is work redesign. What do you do? In North Carolina, there are 16,000 nursing students that are enrolled in nursing schools every year. That apply to nursing schools every year. 7,700 actually matriculate. So the question is, what are we going to do with those 7,700 people? And what we've done is really move to using lean management principles in our Duke quality system at every local nursing unit in an attempt to redesign the work focused on eliminating waste. Sounds, like a trite statement, but when we do time motion studies of nurses' activities, every activity over 250 hours, morning, noon, night, days, weekends, what we find is 32% of a nurse's time in a 12-hour shift is spent documenting. And not documenting the first time, documenting what was already documented in the emergency department, again. And 70% of that information is never looked at by anyone other than the nurse that documented it. Who designed that system? We did. I mean, some of it is regulatory, but unlike physicians, there's no billing requirement for most of that. To admit a patient to Duke University Hospital, a nurse completes 92 fields in the Epic electronic health record. And this is the other drag on the workflow problem, which is we have decided that the way to improve performance is to measure more, to collect more data, and to use the data to micromanage. We haven't decided that we are much better at measuring than we are at improving. And so what we're doing is using lean management principles on these local units with three components: a management system, which creates daily situational awareness on that local unit and is made up of work processes, not outcomes, work processes that then drive the expected outcomes, and all include area improvement activities, which are the focus of the local unit. Every manager and every clinical nurse lead and every medical director in those units goes through a 12-week lean management course to learn principally how to solve problems with a rigorous, disciplined approach. This occasion does not allow us to simply guess. We must be very, very focused in the way we address these problems. And so we have a management system, training people to learn how to do humble inquiry and leader as learner. We have a work system. This is really important. How is work done every day? So we do value stream maps on all of our major care processes. The team does these, led by a lean coach, so that you can see gaps in the daily workflow and then use PDSA cycles to address those gaps. And then the improvement center is about all the other lean management tools that are things like your supply chain. So 15% of the nurse's time in that 12-hour shift is trying to find stuff they need to do their work. My favorite story is a nurse on a neuro unit who took EEG leads. These are leads you place on people's heads when you're worried they're seizing. And because he wasn't sure he'd ever have them, he actually took several packets of them and stuck them in the tile in the ceiling. True story. Because the issue is people don't have what they need to do their work. And they spend 15% of their time running around trying to find it. Those are solvable problems that are, I think, deeply informed by principles of management that are gleaned from engineering. And so that's the kind of process that we're trying to undertake to try and deal with the issue of work redesign. We can no longer say, cope with your overburdened day. That's what we've been trying to do. You know, here's a yoga mat and here's a meal. We need to fix the overburden.